So good morning to everybody. Thanks for this invitation to GIS. And my topic today is to talk about eye bleeding risk and the usage of antithrombotics. As you know, in acute coronary syndrome, we have to balance ischemic and bleeding risk, and which are the current clinical challenges. Potent DABT improves ischemic outcomes. A meaningful proportion, however, of ACS patients meet the criteria for eye bleeding risk. Guidance default DABT optimal is suboptimal for many patients and who benefit from early de-escalation or monotherapy. So what the guidelines mostly are proposing is from standardized regimens toward individualized antithrombotic duration and intensity. And we are talking about this quite wide category of antithrombotic therapy in acute coronary syndromes. We know that there are many factors that are associated with an increased bleeding risk after PCI. And this is a nice illustration coming from the publication of Philippe Urban in 2019 that is enlightening which are the factors that are correlated with increased risk of bleeding after PCI. Clearly aging, comorbidities, lab findings like anemia, low platelet count, but also other comorbidities, bleeding history of the patient, as well as whatever is iatrogenic correlated, as the usage of anticoagulant, planned surgery on patient on DABT. And as you know, it was published then the eye bleeding risk criteria, and this is a kind of table summarizing which they are, and major are if they have BARC 3 or 5 bleeding risk, which is correlated with a 4% of increasing risk at 1 year, and the risk of intracranial hemorrhages of 1% at 1 year. So you have to keep in mind when you are making your decision. What is the recommended default antithrombotic therapy regimen in acute coronary syndrome without an indication for anticoagulation? These are the guidelines of 2023. Clearly, we are in 2025. I will show you that in the meantime, many data and trials have been published and most probably will impact in the next guidelines that are going to be published in 2027. So there is a distinction between ST elevation and non-ST elevation MI. In both of them, you have to have on board heparin as a class 1 recommendation. What about indeed the dual antiplatelet therapy? It's a class 1 recommendation for ST elevation MI to use aspirin before the coronary angiography. Regarding the P2-11-12 inhibitors, indeed is not any longer a class 1 recommendation, it's a class 2B recommendation, and it is even contraindicated in the patient with non-ST elevation MI to do before invasive coronary angiography. Indeed, with invasive coronary angiography, when there is the decision-making of primary PCI, clearly is a class 1 recommendation to merge with a second antiplatelet therapy, which is a P2-11-12 inhibitor, such as prasugrel and ticagrelor that are first line. Only if they are not indicated because of contraindication, you can have clopidogrel. On the other hand, indeed, in the patient with non-ST elevation MI proceeding with PCI, there is a class 1A recommendation to have on board prasugrel and ticagrelor. And then regarding the duration, it's for 12 months generally, and then monotherapy after that. So as we said, regarding the inhibitor choice, the guideline says that first line are ticagrelor and prasugrel, second line is indeed clopidogrel, only if prasugrel or ticagrelor are contraindicated or unavailable, or eye bleeding risk with more than 1 major or 2 minor ARC HBR criteria, or if the patient is more than 70. Which are the current evidence? Current evidence come from trials that actually were designed in the past, like the Plato trial or the Triton TIMI-38, demonstrating the advantage of more potent P2-11-12 receptor as compared with indeed clopidogrel. What about indeed if the patient has on board anticoagulation? In this case, as a default strategy, if they have the triple therapy on board, which is the DAPT plus, indeed, the oral anticoagulation. This goes up to 1 week, only 1 week, and then you have the first 3 months with one single plus the anticoagulation. Then you can go up in monotherapy or with SAPT, and you go with only anticoagulation. On the other side, there is indeed the patient with very high ischemic risk. In this patient, indeed, it can be prolonged, the triple antiaggregation and anticoagulation, but this is not class 1 recommendation. Is a 1B, up to 1 month, and then you go on. So, as I said, it's modulated according to the risk of bleeding or ischemic in patient. What about shortening the DAPT? And this is the evidence. There are 2 trials, the TICO trial and the Master DAPT trial, 2020 and 2021. In the first, ticagrelor monotherapy after 3 months of DAPT reduced net adverse and major bleeding events versus ticagrelor plus aspirin, but matches were similar. And in Master DAPT, indeed, in high bleeding risk, post-PCI, 1 month DAPT, monotherapy versus 3 month DAPT shows similar major adverse cardiac and cerebrovascular event, but reduced major and clinical relevant bleeding. So antiplatelet strategy to reduce bleeding risk in the first 12 months after ACS, DAPT abbreviation can be considered in patients who are event-free after 3-6 months of DAPT and not high ischemic risk. Indeed, for high bleeding risk, consider aspirin or P12-11-12 receptor inhibitor monotherapy after 1 month of DAPT. Again, this is according to your bleeding other ischemic risk. So, practical approach to antithrombotic therapy after acute coronary syndrome PCI, according to the guidelines, assess ischemic risk in ST elevation MI, complex PCI, or prior MI, assess the bleeding risk. There are different bleeding risk scores that have been indicated in the guidelines. One of them is precise DAPT that is currently recommended. Choose DAPT intensity and duration. Low bleeding risk, prasugrel, ticagrelor plus aspirin, 12 months. Consider to stop at 3-6 months with stable and low ischemic risk. Indeed, in the patient with high bleeding risk, you can have the short DAPT according to the Master DAPT result, and then monotherapy with ticagrelor or clopidogrel. And then reassess at 1 and 3 months because the therapy can be dynamic. What are the data coming up later than the guidelines then? This is a meta-analysis of 7 randomized trials, 27,000 patients, comparing monotherapy after a short course of DAPT versus standard 12-month DAPT. And what they come up with, that bleeding reduction without affecting ischemic events, to have monotherapy after a short course of DAPT of 3 months, but ticagrelor had better outcomes than clopidogrel, and clopidogrel monotherapy reduced bleedings but increased MI without any benefit on NACE. And other recent evidence coming in the latest scientific session of European Society of Cardiology, American Heart. These are the trials that were presented. The first is Neo-Mindset trial. This is potent P2-11-12 inhibitor monotherapy soon after PCI as effective and safer, then continued DAPT in acute coronary syndrome patient. The regimen of monotherapy stopped aspirin and continued ticagrelor or prasugrel. Actually, they did not meet the non-inferiority, so the trial was not a positive trial. So in this case, monotherapy was not to be considered because they failed the primary endpoint. However, as always, it was decreasing the major bleeding. Then there is a recent subset analysis that was published, I think, last week in JACC, and indeed did consider to split between STEMI and non-ST elevation MI, and in STEMI there is an higher ischemic risk with early aspirin withdrawal, and in non-STEMI acute coronary syndrome, similar indeed was the ischemic risk, so to be even considered, and clearly the bleeding outcomes were higher when there are combined dual antiplatelet therapy. Tailored CHIP trial, again, this was published and presented this summer because it was one of the trials. Can a tailored antiplatelet approach, early intensified therapy followed by de-escalation, improve outcomes versus standard DAPT in high-risk complex PCI? And in this case, again, there was no difference in the primary composite endpoint between the two, as no difference also in major ischemic events. So you can currently, and indeed there was an advantage of bleeding. So in this case, you could indeed think that a tailored approach could be beneficial. Target First trial was presented again at European Society of Cardiology and published in New England Journal of Medicine 2025. This is a multi-center randomized clinical trial, almost 2,000 patients, and the patients were randomized to 1 month event, free DAPT, to P211 monotherapy versus continued DAPT. And in this case, indeed, the non-inferiority was met, and so the trial was a positive trial. The non-inferiority was actually met as well in the primary outcome as well as in the secondary outcome. And then another very high-risk scenario is indeed the patient in cardiogenic shock. It was proposed to use, for example, cangrelor instead of ticagrelor, but the trial was not a positive trial and the non-inferiority was not met. So at the current time, we cannot indicate cangrelor instead of indeed ticagrelor in the shock patient. Then we should reflect if how many of these patients were on MCS or ECMO on board, but this is a further analysis. Dual ACS trial indeed was prematurely interrupted. What about some specific patients? We did publish a document on women and the need for antithrombotic drugs. I invite you to download this paper. It's very thoughtful, and actually what, if I can go only in the conclusion, and I can conclude. In that paper, it was shown that women has an high risk of bleeding as compared with men, which are the factors. So you have to consider in women specific antithrombotic. We don't have trials, and we have to reflect about that. So take-home messages, potent P2, 11, 12, plus aspirin remain default, but not universal. Clopidogrel has a clear role in high bleeding risk, elderly and intolerant. Short DAPT is evidence-based and safe in high bleeding risk. In standard risk, consider 3 to 6 month DAPT if event-free. Guided de-escalation and current trials emphasize individualization and tailored intervention. Thanks for your intervention.